Minutes and 10 seconds. Okay. Hello, my name is Michelle Weiner. I'm an integrative pain management physician, one of the partners of a practice in South Florida called Spine and Wellness Centers of America. The title of my presentation today is Using the Biopsychosocial Model to Treat Nociplastic Pain. We're going to specifically be talking about ketamine-assisted psychotherapy. So again, I'm the Director of Integrative Pain Management for Spine and Wellness Centers of America. I am double board certified in physical medicine and rehab, as well as pain management and faculty at Southeastern, where I have students who shadow me in the office to learn about cannabis medicine as well as ketamine for all different medical indications. I'm one of the clinical advisors for a psychedelic fund called Eater Investments, and part of our Florida's Medical Cannabis Advisory Board. I was trained during my fellowship in ketamine, but also I was trained by the Ketamine Training Center, which is Phil Wolfson's program, which has more of an intramuscular and psychological component to it that I didn't get during my fellowship. And my research is using cannabis as a substitute for opioids. And then I also have done some work looking at the senior population with chronic pain and the benefits of using cannabis. And I just recently published on intramuscular ketamine for chronic pain and depression. Today, we're going to discuss the types of chronic pain and define what central sensitization is. We're going to review the history of ketamine's medical indications, discuss the psychological and biological mechanism of ketamine, as well as discuss neuroplasticity, review the concepts of set, setting, and dose, as well as route of administration when discussing ketamine and other psychedelics, and the importance of integration. So chronic pain, as we know, is usually defined as pain that persists for more than 6 months. And the actual definition by the International Association for the Study of Pain is an unpleasant sensory or emotional experience with actual or potential tissue damage. So the most important component here is that there is an unpleasant sensory and emotional experience. There doesn't have to be actual tissue damage, which means the physical body may not have tissue damage, but the person is still experiencing chronic pain. So there's a complex interplay between different organs, systems, as well as parts of the body, which could be receiving pain signals. Our peripheral receptors, our central nervous system can get sensitized to pain over time. And then we have the emotional or affective part of the brain that's going to be incorporated in the experience of chronic pain, as well as our behaviors and cognitions. So when someone has pain, there's a neural circuitry that is strengthened over time around the physical and emotional perception of pain. And pain is produced into our consciousness. Pain is there to protect us. It's there to let us know, move our hand away from the stove, for example. And what happens throughout our lives is different experiences reinforce how our tolerance to pain will persist. And by that, what I mean is our brain is like a prediction model. It's telling us, based on our previous experience, what we've learned, how to protect ourselves from pain. And so that's a really important concept, the fact that our previous experience, our pain tolerance may come from many other things besides that exact moment when we started to have pain. There is a shift right now because we have 50 million Americans who have chronic pain, and we had this opioid epidemic. And actually, as we've started to decrease people's opioids, there's been an increase in opioid overdose deaths. And that really stems from the fact that people are getting opioids outside of their physician's office, or they're going through withdrawal because we're trying to decrease opioids. After the pandemic, we have many people who are disconnected, isolated, and chronic stress and inflammation are very closely related. People's behaviors have led towards them leading to addictions from different substances. And so when I talk about a paradigm shift, I'm talking about less numbing our feelings and more bringing them into our awareness and changing the relationship we have. And so we call a lot of these psychedelics consciousness medicine. We're actually bringing pain or bringing our suffering into our consciousness so that we can identify that we are not our pain. Cannabis can be very helpful in altering our consciousness, changing our perspective and how we look at our pain. Psychedelics quiet a part of the brain called the default mode, which holds the story or the personal narrative of who we are. It holds our ego. And ketamine has a different mechanism than the other psychedelics, but it's responsible for potentially reversing central sensitization. And all of these can change the way the neural circuitry is in the brain that we call neuroplasticity. It can change, it's moldable, and they also have anti-inflammatory properties. So a lot of what central sensitization is, and I'm going to talk about, there is some neuroinflammation that leads into depression and chronic pain. And so there's this nice relationship with stress and inflammation and pain and suffering, and it's hard sometimes to separate them. So when we talk about types of pain, the two classic types of pain are nociceptive versus neuropathic. Nociceptive means it's actually physical tissue. For example, someone has a trauma, a fracture, a surgery, arthritis. They have actual pain in the body, in the tissue. Neuropathic is more related to a nerve. Perhaps they have postherpetic neuralgia with burning, numbness, tingling into that dermatome, or they have trigeminal neuralgia, peripheral neuropathy. And then besides the nociceptive and neuropathic, there's this mixed group. Mixed is basically could be a little bit from each, or it could be in the central nervous system. And what I mean by that is things like fibromyalgia, chronic fatigue syndrome, complex regional pain syndrome. Low back pain may be multifactorial. Perhaps someone has joint inflammation in their facets, as well as myofascial pain or pain in the muscles, muscle spasms. They may have stenosis in their lumbar spine, and also, let's say, myofascial pain. So there's a mixed component there. It's not just the nerves, it's not just the tissues. And in the state of fibromyalgia and chronic fatigue and IBS, there's no real objective measures that we can state, yes, based on these labs, these imagings, we know that you have fibromyalgia. That the mixed group is much harder to define with objective measures. So nociplastic pain is now given its own category. They call it functional pain, and it's really a dysfunction in our central nervous system. Processing pain signals may become distorted or sensitized, even if there isn't actual tissue damage. This happens from persistent functional symptoms that are maladaptive. What that means is the person is not able to adapt to their internal environment. The pain could be all over. It could be on both sides of the body, above and below the waist. It doesn't have to follow a specific pathway. They may have other associated symptoms like depression, fatigue, cognitive impairment, and even other sensory and motor symptoms may follow. Now, the classic nociplastic pain or functional pain, central sensitization pain disorders would be complex regional pain syndrome, which is a hypersympathetic response to an injury. Usually someone has a trauma to their foot. They have a brace on for too long. It causes this upregulation of the sympathetic nervous system, and they have sensitivity to pain in that area that may spread throughout their body, for example. Fibromyalgia, chronic migraines, phantom limb pain. They have an amputation. They no longer have their limb, but they have pain where that limb used to live. That's because it's still a process within our brain. And our brain has to reorganize now to understand that we don't have that limb anymore, yet we're still feeling pain. EMJ is another one. And people who take opioids long enough will get opioid-induced hyperalgesia. Their opioids will actually make them more sensitive to pain. And then we have the classic clinical endocannabinoid deficiency syndromes that Ethan Russo discusses. Chronic fatigue, IBS, fibromyalgia, all of these are part of nociplastic pain. And anxiety and depression could also be considered nociplastic. So I look at pain from a trauma-informed lens. And what I mean by that is people who have had chronic stress, there's changes that occur in the sensory processing of their nervous system. So when I get a new patient who has chronic pain, the story behind when did they not have pain, when did they first start to have pain, is very helpful for me to understand why their pain didn't resolve as it should. For example, maybe they've had trauma in their past and this lowers their pain threshold. Your brain is what we call a danger detector. It's always assuming that if there's some danger, that the alarm will go off properly. What happens with people who have chronic pain is that for too long, they've been misinterpreting these signals. So it's almost like an alarm's going off and there's no smoke or fire. They don't want to be touched. They're more sensitive to pain. Things that don't normally cause pain are increasing their pain. And so a lot of chronic pain patients have had trauma that is unhealed and unresolved and living in their body. And so that's why we say neurons that fire together wire together, because the trauma may live in their body and now they believe there is a threat when there really is no threat. So when we talk about pain and psychiatry, it would be nice to have cures, curative psychiatry, or people's chronic pain actually being cured, getting to the root cause of this. For example, using antibiotics to treat an infection as opposed to Tylenol to treat the fever. We are using opioids and benzos to numb the pain, but we're not really getting to the root of why they have pain. And there's been many studies published about people who've had back pain, for example, that may have structural changes on MRIs. However, when we do pain reprocessing therapy, their pain does resolve. So despite the objective measures, their pain may have been from trauma that is now living in the body. There's also studies like the STAR-D trial, which shows that the more antidepressants someone tries, the less likely they are to be successful. So when we look at the evidence, we really have to kind of take a step back. If we are in this state of chronic pain and having this pandemic of mental illness, then clearly we need new ways of looking at the body and the brain and the mind. And showing the connection is really very important for one's healing. But we're missing the root cause. We're just treating symptoms. So there is a relationship between inflammation and stress. We all need a certain amount of stress to get us going, to allow us to be functional and motivated in life. However, too much stress can lead to imbalance in our lives. This is when we see autoimmune conditions, for example. Adverse childhood events increases overall stress, leading to more inflammation. And that's why before I talk about cannabis or ketamine with any chronic pain patient, I always want to know what they're eating, if they're moving their body, and what their social life looks like. Are they married? Are they connected to themselves or others? Do they have support in their life? Candace Pert coined the term body-mind. We hear a lot mind-body connection or psychosomatic, but body-mind really is that oneness between the mind and the spirit and the body. And so disease is impacted by our biology, our genetics, our psychology, our behavior. But if we want to stay well, not just treat our pain, but prevent disease, we need to increase our awareness, increase our connection to ourselves and others, increase our resilience, and be able to adapt. So when we talk about the pain pathway, if you hit your finger with a hammer, for example, while nailing something in the wall, or you have a hot stove that you touch, there's a whole process from transduction, conduction, transmission, and perception. These are the pain pathways that go up and down from the periphery, from your arm or your leg, for example, into the spinal cord, up into different parts of the brain, where then we are able to react to it. We're able to move our hand away, but we also have the perception of pain. And this involves the limbic system. So central sensitization is when these ascending signals become amplified. So going up the pathway, there's too much input up and there's not enough inhibition of the descending. So the brakes aren't on. So central sensitization means our brain and our spine, our central nervous system, is hyperreactive, is more sensitive to pain. This can alter gene expression. This is what we call epigenetics, is changing the way our genes are. It can lead to activation of microglia, which is inflammatory cells, causing neural inflammation. It can also lead to the brain's inability to respond correctly to stimuli. So there's this hyperalgesic or allodynia, which is pain from a non-painful stimuli. So there's many influences that can cause central sensitization. Our excitatory neurotransmitters like substance P, CGRP, and glutamate, the NMDA channel, which is a glutaminergic receptor, the descending pathways where neurotransmitters like serotonin and norepinephrine are involved, as well as our opioid receptors. And then different parts of the brain are involved in processing. For example, our hippocampus, which stores our memory and allows us to learn. Our amygdala, which is our fear response. The thalamus is basically a relay system from the body to the brain to interpret signals. And the prefrontal cortex for us to plan, move our hand away, for example. So there's different parts of the brain that are involved in processing pain. Now, ketamine is an option that I want to discuss for nociplastic pain, this type of mixed pain, where it's not a specific tissue damage it's not a specific nerve, for example, but it's a central sensitization process. And originally, ketamine is a dissociative anesthetic, part of our core medicines. It was used in Vietnam War. It started to be used in 1990 for chronic pain. And then it had breakthrough designation for treatment-resistant depression in 2018. So what ketamine is doing is it's blocking the NMDA receptor, and this receptor is activated in central sensitization that leads to this windup or this hyperreactivity in the nervous system. So perhaps ketamine can play a role in reducing central sensitization, allowing for glutamate homeostasis and cortical reorganization. With multiple sessions of ketamine, perhaps there can be this new neural circuitry, and pain is also an experience. And so there's multiple components there in terms of biological, psychological, and functional mechanisms. It can increase the presynaptic release of glutamate, resulting in higher extracellular levels of glutamate, and also the disinhibition of GABA, which is an inhibitory neurotransmitter. By stimulating AMPA, it increases brain-derived neurotropic factor, contributing to neuroplasticity, changing the way the brain is processing these different connections. It can reverse stress-induced neuronal changes in the prefrontal cortex, and it increases dopamine and serotonin and causes an anti-inflammatory effect. So by blocking the NMDA receptor, affecting glutamate, increasing brain-derived neurotropic factor, increasing neuroplasticity, that's the biological mechanism. Functionally, it can decrease our default mode. It can decrease the part of our brain that holds our story of who we are, that we're too attached to, that doesn't allow us to move forward. And it can also have a psychological input. What was the insight gained during that session? What do you remember from that ketamine session? Julie Holland wrote a book called Good Chemistry. She's a psychiatrist in New York. She said the thing about awe and wonder is they're both exquisitely open states where you're absolutely in parasympathetic. You may be in flow, but you're also primed for new information, open to learning. So awe within itself is a great medicine. There's a concept of the rebus, relaxed belief under psychedelics. The fact that we enter this entropic state during psychedelics. This is Robin Carhart Harris at Imperial College of London. He talks about the ability for the brain to start communicating different networks or integrating with each other. That's when we get synesthesia, like we hear colors, for example. So this entropic state allows us to relax our beliefs about who we are, to recalibrate. And there's even functional MRI studies using psilocybin mushrooms, which is one of the classic psychedelics that activates the 5-HT2A receptor, different than ketamine. And it shows that there's this entropic state where there's different regions of the brain that are communicating, but the default mode is quiet. And this allows for us to be able to be open to new possibilities. If the person has the willingness to change, then perhaps they can expand their mind, have some flexibility, and make a new path, ski down a new path. So ketamine can have multiple routes of administration. The intranasal Spravato is used for treatment-resistant depression. I personally don't prescribe intranasal ketamine. I think it has a high potential for abuse. We sometimes give oral ketamine during a ketamine-assisted psychotherapy session, a low-dose ketamine to act as a lubricant to help the person speak openly about a past trauma. IV and intramuscular are the most common. Usually it's done 2 sessions a week for 3 weeks or 1 session a week for 6 weeks. Intramuscular dosing, I usually give 2 injections, one that follows 15 minutes later. IVs, I usually do more for chronic pain, anywhere from 1 to 3 hour. And we have some evidence that it's effective for complex regional pain syndrome, but we don't have much evidence using ketamine. And that is something that Medicare needs in order for us to get it covered by insurance. We need to see long-term durability data. So I use a biopsychosocial model to treat chronic pain. Why? Because depression and chronic pain coexist in 60% of the cases, and because elevated rates of trauma are seen in patients who have chronic pain. And underlying trauma, anxiety, and depression may really be contributed to central sensitization. So as a pain physician, I've learned a lot from pain psychologists and psychiatrists to not just treat the body, but to treat the whole person. When I went to do my training in the Catskills, actually, with the Ketamine Training Center, we discussed using the intramuscular dose, and we discussed different states of non-ordinary states of consciousness. The first low dose being more of a heart opener. That's using a low dose where they're able to remember everything, and sometimes even doing a little therapy during it. The second is really more of an out-of-body experience. And the third is what people talk about where they have a K-hole or a near-death experience. We usually work in lower doses so they're able to have insight and remember their journey. So if we're giving someone ketamine, we obviously want to know the evidence behind why we're using it, what our dose should be, what route, but also there's an ethical component behind giving someone a medication that's going to allow for a dissociative experience, disconnecting them from their ordinary mind and body. So this can give a mystical experience, that sense of awe. They can reconsolidate a memory, extinguish fear. They have this perception that they're floating like a magic carpet ride through the sky, or they feel that they're traveling through time. Perhaps they don't feel the boundaries within their body anymore. And this ego disillusion where they're not in their conscious mind to make the decisions based on their default mode, based on the story of who they are. It allows them to have this flexibility so that they can expand their awareness. Instead of looking at the same lens that's very limited, they are able to see more than they're usually able to see and distance themselves from the pain that they're going through. Now, the using ketamine is an art in terms of the dose, the route, and finding the sweet spot for the person. But I think it's very important to remember the journey within itself is very important. It's not just the medicine. And so that's why the preparation is so important, so that someone feels prepared before going into a ketamine session. They have the therapist, the coach, the physician. We call ourselves a therapeutic alliance. They're aware of the setting. They're comfortable. They're lying in a recliner. They have eye shades on and headphones. They're listening to a playlist that has no words directing them towards any type of feeling or previous experience. And we pick a specific belief they have about themselves. For example, I'll always have pain. I'm powerless. I'm not good. And we talk about what they want instead. They want to have a life without pain. They're willing to distance themselves from the pain and feel that they can take power over their lives again. So we anchor this intention into their session right before they go in, so they have a clear intention. And then whatever comes up, and we're there to support them. It really does help with past traumas, and for them to understand why they're in chronic pain. There's always a story behind it. When was the last time you didn't have pain? Well, right before I fell and fractured my shoulder, that required 3 surgeries after it was infected, and then I was a caregiver for my husband who was sick for 5 years with cancer. So there's always a story that leads up to this wind up phenomenon, this um, increased reactivity that's living in their central nervous system. It's never just one thing. And so it's important for them to understand that all of these are components that led them here so that they can understand how to reverse this and move forward with a different direction. This is an example of what a ketamine session would look like. It's a very comfortable environment. You don't want it to look too clinical and sterile, but there still needs to be this feeling that they could let go, surrender, and trust what's about to come up. So they have to feel secure and safe. And then integration is really how to allow for long lasting effects. And psychedelic, the word means mind manifesting. So we're helping these people feel connected to themselves, to feel like their lives are meaningful. And so it's not just the substance, but it's the integration of the memories during those states that become so salient. They remember where they were filled with love and peace. They remember having a body that didn't feel pain during that ketamine session. And they're able to go back and revisit that. And so these states are really what is most important in how we can make long lasting change. It's a catalyst when someone is so depressed they can't move forward in life. It's a catalyst to connect them with themselves, to make them feel less pain or love or peace, to overcome their defense mechanisms, to de-pattern, to help them form a new practice on a daily basis. And so a lot of times we use a therapist who's trained in ketamine assisted psychotherapy to assist in this process so that they can change their limiting beliefs and change the perspective so they're not defined by their pain. Their identity is more than just their condition, for example. So this paradigm shift in healthcare is really stemming from the fact that we shouldn't be taking a daily medication to numb our pain. We need to get to the root cause, which may have been years back, but we still need to treat the entire person. It could potentially reverse central sensitization, maintaining that glutamate homeostasis when we treat unhealed trauma and also focus on stress resilience. And so the mind informs the body informs the mind. It's important that we understand the body puts is a construct that puts pain into our consciousness. And so we really thank Rick Doblin, who you see here in the picture, who is the head of MAPS, which is the organization that's raised millions of dollars for psychedelic and consciousness medicine. So there's all different pharmacological agents that we can use to treat pain that is involved in peripheral and central sensitization, from the anti-epileptics like gabapentin and Lyrica, SNRIs and TCAs, which are antidepressants that we also use for musculoskeletal pain or neuropathic pain that affects serotonin and norepinephrine, that descending inhibitory pathway, and as well as working on glutamate and GABA. So these are all the pharmacological ones, but we also have to look at what's going on, not just biomedically, but psychosocial. What's going on at home in their environment? What are their relationships like, their family unit? This is a picture of me with Bessel van der Kolk, who wrote The Body Keeps the Score, which is a great book, which really explains this type of nociplastic pain and how unhealed trauma and our environment can lead to us having more pain and suffering. One of the biggest issues is the ketamine is not covered by insurance, which we are working on. They just need long-term data. And cultural factors, the stigma behind using psychedelics, for example. So we can treat pain either by decreasing that amplification of the ascending, or working on the descending inhibitory pathways, or by talking about the perception of pain. And there's a quote by Gabor Mate, who wrote the book, The Myth of Normal. Every human has a true, genuine, authentic self. The trauma is the disconnection from it. The healing is the reconnection within it. So what we're trying to do is have the person connect with their truest, highest, wisest self, understanding that they are not their disease state and that they can move forward in their life in a different pathway. And we do that by supporting them, not just by giving them a medicine, but by giving them coaching, therapy, and making them understand, giving them pain education. This was a study that I did that was using intramuscular ketamine for chronic pain and depression, because the intramuscular dose route is comfortable and easy to use, can be done with multiple injections, and it's more relational. And so really the goal is this balance and increase in flexibility and the ability to move forward in their lives, but understanding that chronic pain can be treated when you treat the whole person. And I believe that's it for me. Thank you.